Welcome, my name is Stefan Hartmann, PA, Iron Direct Primary Care Provider. I'm bringing you all the first in my series on low testosterone and part of the metabolic syndrome. I'm going to be getting into more of testosterone as I want to introduce my patients and potential clients to what iron DPC is doing, which is bioidentical hormone replacement. This series will provide an educational experience to dispel some of the myths surrounding testosterone and hormone replacement, and a better understanding for clinicians alike of how it's so important and unfortunately an under-recognized tool in our toolbox to helping patients reverse disease. So testosterone, we'll start here. Why is testosterone important? Well, it's the most important sex hormone among males and significantly impacts men's physical and psychological well-being. Patients with testosterone deficiency syndrome may experience hypogonadism, a condition defined by low serum testosterone levels, combined with clinical symptoms. This condition is associated with various comorbidities such as metabolic syndrome, cardiovascular disease, erectile dysfunction, atherosclerosis, respiratory problems, depression, and other complications that reduce overall health indicators. So, contrary to popular belief, high testosterone is a good thing, and low testosterone is actually associated with increased risk of dying from a heart attack. It looks like I froze right here. Let me get myself pulled up. Okay, there I am. I'm back. Hello. View, float on top. Here we go. All right, next step here. Obesity, a driver of low testosterone. So we have a very interesting catch-22, where the patient who is obese gets a low testosterone, right? And patients who have a low testosterone, they're more likely to become obese. And it's a very, very difficult cycle to break. The single most significant risk factor for testosterone deficiency in men is obesity. The pathophysiological mechanisms involved in male obesity-related secondary hypogonadism are highly complex. Obesity-induced increase in levels of leptin, insulin, pro-inflammatory cytokines, and estrogen can cause a functional hypogonadotrophic hypogonadism with a defect present at the level of the hypothalamic gonadotropin-releasing hormone neurons. The resulting hypogonadism by itself can worsen obesity, creating a self-perpetuating cycle. So I know that was a lot of words, but needless to say is that it's a vicious cycle, and it's very hard to break. Otherwise, we wouldn't see such an epidemic of low testosterone and obesity everywhere in the U.S. And we're going to get more into the epidemic of this in the next lecture. Metabolic syndrome and hypogonadism, a bidirectional relationship. So the higher the number of metabolic syndrome components, the lower the testosterone levels will be. However, low free testosterone levels are not consistently associated with metabolic syndrome risk. Two recent studies in hypogonadal men, in which the association between total testosterone and metabolic syndrome were adjusted for sex hormone binding globulin, concluded that it is not total testosterone, but sex hormone binding globulin that is independently associated with metabolic syndrome risk. Insulin resistance in testosterone deficiency is mediated by body composition dependent effects, including increased adipocyte differentiation, so visceral adiposity, which is fat on the abdomen, and decreased myocyte differentiation, sarcopenia. And we've talked about that one before, so a muscle wasting phenomena. And body composition independent effects such as increased inflammation, TNF-alpha, IL-6, and IL-1, decreased adiponectin, and reduced mitochondrial function. So that's why when I do my laboratory evaluations on patients, I check several hormone markers, including sex hormone binding globulin. Hypogonadal obesity adipocytokine hypothesis. Why the body can't just make more tea, which would be great. It would fix a lot of problems. The hypogonadal obesity adiponectin hypothesis is an extension of Cohen's theory, which explains why the body cannot produce compensatory testosterone via increased gonadotropin secretion and subsequent stimulation of the Leydig cells. In obese individuals, enhanced aromatase enzymes produced by adipose tissue reduces testosterone and increases estrogen hormones. Testosterone deficiency facilitates further adipocyte differentiation, adipocyte inflammation, and insulin resistance. The resultant increase in estrogen, leptin, insulin, and inflammatory cytokines results in this syndrome. So, as we get less testosterone, we get more fat cells. In obese individuals, the reduction in testosterone, it increases estrogen hormones. And this is because the more fat cells we have, the more estrogen that is produced. And as I say again, a very difficult cycle to break here. More on this vicious cycle here. If you're interested in the pathophysiologic mechanisms, I recommend reading this article here, but we won't get into it too much here. Here's another diagram of it, a very complicated diagram here. A lot going on this one. I think I might put this up on my Instagram page for people to look at. Secondary hypogonadism. So, secondary hypogonadism has therapeutic implications. This is where we're interested in, right? How can we help people? It can result from functional causes, obesity, type 2 diabetes, opioids, so narcotics, and systemic disease, and can be reversible with treating or preventing these conditions. And I would add alcoholism. So alcohol increases estrogen through several pathological mechanisms. The alcohol gets converted to estrogen. So the whole old, propaganda that men drink beer, Vikings strong, is actually not true. The more beer and alcohol, specifically beer you drink, the lower testosterone you're going to have. Let's see. Studies suggest that obese men can increase their testosterone levels upon weight loss, either by supervised diet, exercise, or in extreme cases, bariatric surgery, which I'll talk about in another time. Other treatments may make use of hormonal replacement therapy or testosterone gel supplementation, in which testosterone treatment reduces visceral adiposity and waist circumference. So there's a lot of ways to do this, and we'll get into treatment modalities a little bit later. I'll discuss natural ways to treat low T in the next episode. Diagnosing testosterone deficiency, you want to get a couple blood markers. You want to check estrogen, estradiol. You want to check total testosterone levels, sex hormone binding globulin. You want to check your thyroid too. Unfortunately, men, they're not tested for this. If you go to your regular doctor, it's not on a standard lab panel. No one tests for testosterone deficiency in men. Women's health services are pretty comprehensive, mammograms, cervical screening, gynecological services. This is great. They have gender-specific studies. But men, we don't really get that. Maybe we get a PSA, a prostate-specific antigen test. Other than that, not really specific for our hormones. Just because modern or conventional medicine doesn't consider it important. It is, though, unfortunately. Testosterone replacement therapy in hypogonadal men provides a 9 to 10% increase in 5-year survival rate, like eugonadal men. Yet a significant obstacle is that few men seek health care despite treatment options. Well, you have to go to the right practitioner, right? This problem is even more acute in developing countries confronting income inequality and unequal access to healthcare services. Yeah, I'd say it's even bad in the U.S. here. I've worked for regular practices, and testosterone is the furthest thing from a general practitioner's mind, typically. Here goes a little bit into a diagnosis and management of that. We won't get into that too much here. We're going to do that in another lecture. Low T, something that only bodybuilders care about. Enter COVID-19. So the majority of male patients with COVID-19 present with low testosterone levels on admission to intensive care in Hamburg, Germany, a retrospective cohort study. And these men with low T are more likely to die of COVID. Very sad, but that's what we're identifying here. Testosterone, a key hormone in the context of COVID-19 pandemic. Let's see. Hypogonadism is associated with a prevalence ranging from 22% to 69%. In this context, low testosterone levels can cause a reduction of respiratory muscles activity and overall strength and exercise capacity. whilst normal circulating testosterone levels show a protective effect on several respiratory outcomes. And they were doing a trial on oxygen consumption in men receiving testosterone replacement and saw positive. That's cool. Testosterone and metabolic syndrome, a meta-analysis study. So Met-S patients showed significantly lower total or testosterone plasma levels as compared to healthy individuals. Similar results were obtained when Met-S subject with and without erectile dysfunction were analyzed separately or with Met-S criteria. So meta-regression analysis demonstrated that type 2 diabetes increased Met-S associated testosterone fall. In multiple regression model, after adjusting for age and BMI, both type 2 diabetes and Met-S independently predicted low testosterone. So we're going to be looking more at some of the uncertainties around testosterone replacement in other lectures, but needless to say, for this lecture, testosterone deficiency is associated with metabolic syndrome, obesity, and increased cardiovascular risk. Testosterone deficiency drives inflammation and insulin resistance. Obesity drives low testosterone, and low testosterone drives obesity in a vicious cycle. Once obese, it is not possible to produce proper testosterone. Increase of estrogen is the physiological result of being obese. Secondary hypogonadism has therapeutic implications, and we're going to talk about how to reverse this in the next episode. There's been a lot of focus on women's health, which has been great, but there is a stigma against testosterone replacement therapy due to its abuse in bodybuilding. That's unfortunate, because this is a powerful tool that we need to recognize in our practitioner toolbox to help patients get better. Hope you guys enjoyed this lecture, and stay tuned for the following episodes, and stay tuned for my lecture series about my visit to the Anti-Aging Medicine Congress, the 29th cycle of this one. I'll be in Las Vegas and be learning a lot about bioidentical hormone replacement, the latest cutting-edge tools that savvy practitioners are using to reverse disease, enhance lifespan. So that's going to be awesome, and I'm going to give you all the details on that. See you soon.